Hi everyone, this is Neel Raithatha, consultant audiologist and director of earwax. Thank you for joining me in my latest video using the iClearScope endoscope. And we have a patient who attended with bilateral otitis externa. So for anyone new to my channel, otitis externa is an umbrella term given to an infection and or inflammation of the outer ear. And the outer ear consists of the ear canal, the pinna, also known as the auricle, which is the piece of cartilage that looks like a wing on either side of our head, and the outermost layer of the eardrum. So the eardrum is actually 3-ply thick. The more lateral layer is lined with the same skin, the epidermis skin that lines the inner 2/3 of the ear canal. The most deepest layer of the eardrum, which is in the middle ear, is lined with mucosal skin cells. So the mucosa is the skin that lines the middle ear, and you can think about the mucosa being similar to the skin that lines the inside of your nose. It's a slight difference to the skin cells that line the middle ear in comparison to your nose, but it's not too dissimilar. And then the middle ear of the eardrum is the fibrous layer, so we have connective fibrous tissue there. So if you've got an infection or inflammation of the auricle, also known as the pinna, the ear canal, the outermost layer of the eardrum, we term that otitis externa. Now this patient suffers from chronic otitis externa and they have to get their ears regularly cleaned. They typically have appointments scheduled for them on a regular basis at the ENT department, where they attend on an outpatient basis and they'd see the ENT nurse. But the way the waiting list is at the moment, this patient's appointment has been cancelled a few times. Now, what's the cause of this patient's chronic otitis externa? They are very careful to avoid water entering the ear. Initially, they used to get water in the ear and that used to trigger it, but they are very careful, and that's reduced the frequency now that they suffer from their otitis externa. And therefore, on this occasion, I've written to the patient's GP just to request a swab, because they are typically given antibiotics for a bacterial otitis externa. Now, with someone who suffers from chronic otitis externa, then there's a possibility this could be fungal in nature, and if it's fungal and they're being prescribed antibiotics, it can actually lead the fungal infection to exponentially get worse, because the antibiotics, not only does it kill or inhibit the growth of harmful bacteria, but it also kills or inhibits the reproduction of healthy bacteria that live in the ear. And in the absence of any bacteria, the fungi has less competition, so they can have an overgrowth. Now, this patient also has an autoimmune condition. So if there is a bit of an overgrowth of some fungi in the ear, then it could trigger an autoimmune response and leading to inflammation of the ear. And when you have inflammation of the ear, or any parts really where the skin, the increased blood flow promotes additional skin formation, and the more skin that's being secreted and generated in the ear, it will eventually die, and that skin should shed naturally from the ear. But if you've got an excessive amount of dead skin shedding in the ear, it can then collect. That then itself can get infected because the fungi can feed off it. It's got more shelter, more food. So it's important to kind of see what the root cause of this patient's infection is. Now, it could be that originally they had a bacterial infection, and with the use of antibiotics it resolved that, but then it led to a secondary fungal infection, which can occur after prolonged use of antibiotics. So again, for anyone who's new to the channel, we've got a natural skin flora, which is basically an ecosystem of bacteria and fungi that reside on the surface of the skin. And the bacteria and fungi seek shelter and food from the ear canal. So the ear canal can help the inhabiting bacteria and fungi to kind of live, but without really overproducing and leading to an ear infection. So it's kind of a one-way relationship. The ear canal really doesn't benefit from much in return. I think previously I called it a symbiotic relationship, but that's where both parties benefit. But this is a commensal, hope I pronounced that correctly, where it's kind of a one-sided relationship in that sense, in terms of the fungi and bacteria benefit where the ear canal doesn't. But that's your normal skin flora. Now, the bacteria that normally reside in the ear canal, they are called acidophilics. So they prefer acidic conditions, which the ear canal should normally be. Our ears are mildly acidic, and earwax itself is mildly acidic. So earwax is believed to have some antimicrobial properties. It helps to prevent the pH level. So just caught the patient there, just found it slightly uncomfortable, so that's why she moved, but it was fine. It was okay for me to continue. In fact, I didn't even come out the ear, I just carried on. So what I'm trying to do is clear as much of this dead skin, debris, discharge from the canal wall as possible and as safely as possible. When you have a bacterial infection, you typically don't get an overgrowth of the normal bacteria, the skin flora bacteria that resides in the ear normally. Instead, you have what we call neutrophilic bacteria. So bacteria that thrive more in more neutral pH level conditions or more even alkaline. And they are not normal inhabitants of the ear canal, so they are from elsewhere. Water can be one of the main causes because there's a particular neutrophilic bacteria called Pseudomonas aeruginosa. Again, I hope I pronounce. I'm very poor at pronouncing certain things, and this is normally found in tap water, amongst other places. And if this enters your ear, and your ear has lost its natural acidic mantle, then it can lead to the overgrowth of this Pseudomonas aeruginosa bacteria. And that bacteria is what we call a gram-negative bacteria. So you typically get two types of bacteria. You get a gram-positive and a gram-negative. Now, the gram-positive bacteria has a very thick cell membrane, whereas the gram-negative bacteria have a very thin cell membrane. However, the gram-negative bacteria is then encapsulated in a thick lipid capsule, and it therefore makes gram-negative bacteria a bit more resistant to antibiotics. They're a lot more of a harder bacteria to fight off. And with gram-negative bacteria as well, they can mutate to become resistant to any antibiotics, and any mutations it develops, it can pass on to neighbouring gram-negative bacteria. So they are very difficult bacterial infections to treat. When you have a bacterial ear infection, it's not due to an overgrowth of your normal skin flora bacteria. However, with fungi, the most common fungi found in the ear is Aspergillus, and you have different strains like Aspergillus niger or flavus, for example. And then you have Candida, and these are natural fungi that reside in the ear. So when you have a fungal infection, you don't have really typically other strains of fungi, although you can. It's normally your natural skin flora fungi, and there's an overgrowth of that. And when you have an overgrowth, it can elicit an immune response, which then causes inflammation or dead skin. And so because this patient's got a lot of dead skin, they weren't really suffering from pain. So another symptom of bacterial infections is pain. So if you press on your tragus, for example, which is the triangular piece of cartilage just in front of the entrance of the ear canal, or if you pull your pinna, the auricle, back and there's a bit of acute pain there, that's more symptomatic with a bacterial infection. This patient, other than having obviously not being able to hear and block, they're experiencing itchiness. Itchiness is, again, more of a hallmark with a fungal infection. So we have got this patient referred to their GP just to get a swab taken, just to make sure whether this is bacterial or fungi, and then it can be treated accordingly. This patient's ear canal was very, very narrow, and sometimes it's hard to tell just how narrow it was just by viewing the video, but it was very difficult at times, especially on their right side. So this is their patient's left ear. The right side is even more difficult to treat. They had a bit of a retraction pocket here. It was a mild retraction in the posterior superior quadrant, and there was a bit of discharge there. So when the patient flinched, I was just working in that area because I wanted to clear that just to make sure there's no underlying cholesteatoma. Now, a cholesteatoma is a dead skin cyst that typically forms in the posterior superior quadrant. So the posterior superior quadrant in this patient's right ear would be about 2 o'clock. And that then a cholesteatoma can be very dangerous because it's self-growing and locally destructive, and it can grow into the middle ear, this dead skin cyst. It gets bigger and bigger. It releases proteolytic lysosomal enzymes, which is the digestive enzymes. That's what causes the destruction of adjacent structures like the three bones in the middle ear, the eardrum. And a cholesteatoma can grow inwards into the middle ear, so it can affect the facial nerve, the seventh cranial nerve, which runs through the middle ear. It can grow upwards towards the brain, the meninges, so it can cause a brain abscess, meningitis, and it can grow backwards in the ear via the eardrum into the mastoid cavity. So the mastoid cavity is the bone behind your ear canal. So, and then there's obviously bacterial involvement as well with the cholesteatoma. So the normal space these cholesteatomas grow in the ear is in the posterior superior quadrant, or the attic, the top part of the eardrum. So whenever I see discharge there, I just want to clear that area just so I got a good visual, just to rule out a cholesteatoma, which this patient does not have in their left ear. The guys, sorry I haven't posted much. Just been really busy. Don't want to. When the time's right, I can tell people what's been going on. I just don't want to jinx anything at the moment. But as part of what's been going on in the background, I've just been really busy developing and having accredited a quality management system. So a lot of you know that obviously I manufactured the iClearScope endoscope, which is the device that I'm using here. Also the wax scope, which is my other device. And I've recently launched my own range of ENT micro instruments. I'm also soon to be launching some suction tips that I've developed. And when you manufacture medical devices, you have to ensure you have got what we call a quality management system, which is basically a set of processes and protocols to ensure that the medical devices that you're putting into the market are being monitored, they're being regulated properly. If there's any issues, you should have procedures and steps in process to deal with these. So there's a lot involved. And so I've already got a quality management system, but I've decided to upgrade it into one that's accredited, and it's called ISO 13485. And there's a lot of work behind that. So just been really busy with that. It's something else I've been busy with, but sorry I have not uploaded in a few days. Also, a big thank you. I'm not sure what's triggered it. I've mentioned it on my other video that I'm uploading today on my other YouTube channel, Clearwax, where I upload videos of the wax scope. But I think yesterday in particular, I've received 3 emails from avid viewers and supporters and followers of the channel, just really saying thank you to me, and some really nice, kind words. So I just want to take this opportunity to thank everyone who watches the videos. It means a tremendous amount. Sometimes I don't quite understand why everyone watches still, so it's a bit alien to me still. But no, it's very kind of you, and I'm glad that the videos help in some way. I know people watch the videos for different reasons, so whatever your reasons are, thank you so much for following and watching. It means a tremendous amount, and thank you. So this ear was a lot more difficult. It was a lot narrower. I'm using the fine end here, and I've got different types of fine ends, and what I mean by different types, they have different angulations, different lengths. And I think this part, I'm using one of my other ones where it's a bit longer and the bend is a bit more proximal. So I'm using different suction tips to what I used to use probably 6 to 9 months ago even. So the normal suction probes that I used are, you have the steel capillary tube, which you can see on screen, and this is normally, in the UK at least, it's different elsewhere, it's bonded directly to a handle. So it comes in one piece. You've got the steel capillary tube, so the catheter, if you like, and that's bonded either via injection molding or by some resin directly to a handle. And if you want to use a fine end, it's a separate capillary tube that you then push into the end of this suction tube here. So that's what I normally use. But 6 to 9 months ago, I've changed to a different system, which is more actually speaking to other countries a lot recently. It's probably more normal elsewhere in the world compared to the UK, whereby you have a separate handle and a separate suction tip, and you connect the suction tip to the handle. So we use a Lewis slip connector. So basically, the suction handle has the male part and the suction tip has the female part. So the steel tube on these Lewis slip connecting suction probes, the steel tube is bonded to kind of a cap, a base, and that's the female part, and you just push that onto the handle, which has the corresponding male part. And the beauty with this is that you can rotate the suction tip on the handle, because some people prefer to hold the handle using what we call a thumb grip, other people prefer using a pen grip. With these predefined suction handles, you have to source the one that you want to use, because once the steel tube is bonded directly to the handle as a permanent fixture, you can't really rotate it. So with this, you can actually rotate it. And if I want to use a fine end, I just simply remove the normal suction probe we use for microsuction, which is in the UK a 14 gauge system. I just take it off the handle and attach the fine end suction probe, which is an 18 gauge or 17 gauge that I'm using more and more now. So you don't attach the fine end to the end of the normal suction probe. You just basically take the normal suction tip off and replace it with a different size, and you can get all different types of sizes. So I'm definitely launching 3 sizes, but I might just do the full range actually. And then see which ones are the most popular and focus on those. But with these suction tips that we attach, you can have different lengths. The bend can be in different places. So I've got a couple of different types of bends that I'm using at the moment, and some angulation and lengths is sometimes better than others for different parts of the procedure. So I'm alternating quite a lot now between the suction tips. So just working very carefully now on the back part of the ear canal. So the ear canal itself is clear. You can see that right at the beginning of the procedure there's a lot of discharge. It just wasn't visible, but I just want to mop as much of this off, and now I'm not going to get all of it out, guys. Spoiler alert. So it's a really tricky procedure, and this patient's ear is infected already, so she wasn't experiencing much pain actually, but it was a bit tender. So now a lot of you may be thinking, why don't I use water now? I'm not a big fan of water, even in normal healthy ears, but certainly not in this case, because this patient's got an ear infection. So you should not be using any water in an ear that's infected. That's one of the contraindications. So that's why, just in case anyone's wondering. So I'm just going to spend a bit more time delicately going onto this patient's eardrum. So we are directly making contact. I'm just bringing this away. Now the eardrum itself, it's got a thickness of 0.1 millimeters, or 0. I'm just trying to think. I've just lost my bearings there. Is it? Yes, it's 0.1 to 0.2 millimeters. It's there or thereabouts. So it's wafer thin, but now I'm not saying the eardrum isn't fragile. It of course is. It's quite easily possible to perforate this, but given its thickness, it's a lot stronger than you would think it would be, given it's that thin. But that doesn't mean we kind of poke and prod without a care in the world, because it would still be painful, and there's always a risk of perforating the eardrum. So I'm just carefully going onto that, can see the entrance of the ear canal is very scabby as well. So I can see more or less the eardrum now. This is the umbo, this is the centre part. There's a bit of discharge here. So I'm just... difficulty with this type of discharge, it's kind of, it's like quite sloppy and sticky. So we achieve to get onto the eardrum, which is obviously difficult itself when you've got an infected ear and it's really narrow and closed. And we've got the endoscope there, we've got the perfect visual, and you get the sucker on the eardrum, but it just sometimes doesn't want to suck away because of the consistency, which is, it can be frustrating because you've done kind of all the hard work getting there. You can see it's just coming away in little bits. This is the anterior recess. And the reason why I'm just mopping up as much as I can, it just allows any topical medication this patient has to have the most effect. And of course, I'm not going to get every last bit, because if I try and get every last bit, I risk causing trauma. So the bits that I feel comfortable removing without causing any trauma to the patient, I'm going to do. I do have a bit of a retraction in the posterior superior quadrant as well. But again, we've cleaned much of that area up as possible. That no obvious signs of a cholesteatoma. This is the inferior recess. Again, this is a bit tricky to get into because of the narrow entrance. I'm just kissing the surface there. I think I'm more or less done now. I just go, yeah, it's going a final view. So if you look at the before and after, there's a big difference there. Well, I hope you enjoyed that video, guys. Do take care, keep well, speak soon. Bye.